Hello, can you hear me? I can't hear anything. Is the admin around? I can't hear anything from the chairperson, as well as from the president. Ronnie, can you hear me? Ronnie?
I can hear you, Tim. Can you hear me?
Yeah, I can hear you now, Ronnie, but I cannot hear
No, I couldn't hear anybody either. I think
Sri Lankan
they're also,
side.
if you look at the comment section, a lot of other people are also having the problem
Oh, okay.
on the right of the chat. So,
Oh, okay.
okay, they could hear you now. I think they could hear you if you look at the most recent chat. Yeah, you could probably start. On the comments.
Okay. Nirun Kanishka, can I start now? Yeah, now okay, okay. Okay, good evening, everyone. I'd like to thank the College of Sri Lanka for inviting me to give this talk. I feel very funny because I cannot hear anything except for myself and Ronnie George. But I hope you can hear me. My talk today is on the management of NTG and update. I'd like to acknowledge some disclosures, particularly that Allegan invited me to give this talk. So I come from Singapore, and this is a small country in Southeast Asia. And these are some pictures of Singapore. Last year, of course, we had the COVID shutdown for almost 2 months, and this is when Singapore became completely empty on the streets. And this is the picture of Changi Airport in Singapore. And this is one of the world's busiest airport. But right now, it's running at 2% capacity. This is my hospital, the Singapore National Eye Centre. So my talk is on normal tissue glaucoma, and it's a form of open-angle glaucoma in which you have a glaucomatous optic neuropathy, a visual field defect, but the intraocular pressure is within the statistically normal range for the population. Please note that it's not a one single disease, but it's probably a spectrum of diseases. And so when you say the patient is normal tissue glaucoma, there could be subtypes of this disease. Now, many population-based studies show that most of the glaucomas, open-angle glaucomas that you find in the population are actually have so-called normal tissue glaucoma because the IOP is within the statistically normal range. And the studies can vary, but as much as 70% of all newly diagnosed open-angle glaucoma are in this range of normal pressure glaucoma. And this prevalence increases with certain races and ethnicity, and particularly in Japan, in Korea, and in some of the Chinese population-based studies as well. They found very high prevalences of normal tissue glaucoma. So is it a different disease from open-angle glaucoma, or is it just a spectrum? I believe it's just a spectrum, but there have been some studies that looked at differences between so-called normal tissue glaucoma and high-pressure glaucoma. And this, for example, they found that there's often a thinner neuroretinal rim, especially inferiorly and infratemporally. There could be notching, more commonly in the inferior temporal area. And there's often optic disc hemorrhage, which I'll go through later, which is associated with progression. The optic disappearance can vary between the senile sclerotic with pale, shallow sloping neuroretinal rims, especially those with vascular diseases, to a focal ischemic type of notching on the rim. And it's often associated with beta zone. The RNFL defects can be localized as well as central. And visual field defects have been found to be a little bit different in normal tissue glaucoma compared to high pressure open-angle glaucoma. They're often more focal, deeper, closer to fixation, and often a paracentral scotoma. So these are some of the differences that have been described. In terms of intraocular pressure, they found that the IOP is often higher. Maximum IOP is correlated with the development of disc hemorrhage, and IOP reduction results in lower rate of progression, which I'll cover later. In terms of asymmetry and IOP, there's conflicting reports. Some shows that worse IOP loss occurs in the eye of the higher IOP. Myopia is often a risk factor as well in normal tension glaucoma. And in terms of disc hemorrhage, as I mentioned earlier, is found to be much more common in normal tension glaucoma, often linked to the rim notching or the localized RNFL defect, and with corresponding visual field loss in that particular area. And this is a risk factor for progression is as much as 5 times. Many patients with normal tension glaucoma often have some kind of a non-ocular vascular dysfunction. They may have symptoms of vasospasm, such as migraine, and there's also some association with Raynaud's phenomenon, often having cold hands and feet. And you can often ask your patients, they will say that they feel very cold easily in the air condition. They'll have to wear socks or even wear gloves. There's association with some cardiovascular conditions, including systemic hypertension. Nocturnal hypotension is particularly important. They found to have a greater nocturnal drop in the blood pressure. And this is associated with progression as well. And there's often silent myocardial infarction, ischemia, as well as hypercoagulability states have been associated with normal tension glaucoma. There have been some reports of immune-related disorders, as well as higher C-reactive protein. And some patients with NTG have also signs indicative on MRI of cerebral ischemic changes. In my practice, I have found a particular association between normal tension glaucoma and ocular obstructive sleep apnea. In particular, I find that many of patients who have unilateral glaucoma or asymmetrical glaucoma, they often have sleep apnea, and they also have a very interesting association of being side sleepers. And this is a very interesting thing which I'm actually studying right now. But there have been some reports of a greater association between obstructive sleep apnea and glaucoma. And this is, some studies showed a much greater risk of having glaucoma in patients with sleep apnea. And the hazard ratio is between 1 to even 10 times. Now, we don't know why do they have this association, but they believe that could be the recurrent hypoxia when you have sleep apnea episodes. There could be some autonomic deregulation, oxidative stress, as well as inflammation linked to the hypoxia, and perhaps even decreased cerebral perfusion pressure. Now, particularly, there's very interesting reports of increased intraocular pressure of course, in supine position, also with obesity, and particularly there could be some association with raised intracranial pressure, and this could also be related to the optic neuropathy. Now, my interest is actually particularly in sleeping position. I find that many of my patients with asymmetrical normal tissue glaucoma are side sleepers, and there have been studies showing that side sleeping is associated with higher IOP, particularly the dependent eye, and there have been also reports of normal tissue glaucoma associated with sleep position. Now, in my practice, I find that it's often the opposite side. That means if they are sleeping on the left, they often have the glaucoma on the right. But it's not a fixed association. Some are also on the same side, so we really don't know what to make of this. And I cannot explain why it could happen in the opposite side. And here's some studies from Korea. They looked at this and they found that 30% of the normotension glaucoma preferred the side sleeping position, and often the worst eye was the dependent eye. And also, but this is not exactly association. It's not a consistent association. Sometimes it could be the opposite eye as well. Now, there have been some papers in the last few years showing a possible link with low CSF pressure, and this came from work from Beijing, particularly by Ning-Li Wang, and they found that people with normotension glaucoma often have low CSF pressure. And a lot of papers have been written by Killer et al., Hans Killer, and he is also particularly interested in the relationship between CSF pressure and glaucoma. Now, why is there this association? Now, if you can imagine, the optic nerve has a sheath around it where there's a subarachnoid space with CSF. And so at the lamina cribrosa, there's an interplay between IOP in the eye, and on the other side of the lamina, intracranial pressure. And they think that the low intracranial pressure may result in increased susceptibility to intraocular pressure, even within the normal range. So in terms of progression for normotension glaucoma, they've been found that women was associated with a greater risk of progression, particularly women with migraine and people who had untreated migraine. And of course, disc hemorrhage. So when you have a patient with suspected normotension glaucoma, of course, I often take the family history. I look for associated conditions such as blood loss, migraine, hypertension, vasospasm, sleep apnea, also previous steroid use or other drug intake. Of course, you will do a proper assessment of the eye and also often look for diurnal fluctuation. I would do visual fields and optic disc examination on a regular basis. And PET imaging will often find a thin corneal thickness. Now, before you label the patient normotension glaucoma, you must always think whether there could be other kinds of glaucoma simulating normotension glaucoma, for example, other forms of glaucoma with diurnal fluctuations, people who had a previous IOP spike with high pressures which resulted in the optic nerve damage, but subsequently they didn't get progressive damage. This also could be a possibility. Of course, think of other diseases of the optic nerve, as well as other causes of optic nerve abnormalities, including infections, multiple sclerosis, and drug toxicity. So when should we consider a neuroimaging or MRI of the anterior visual pathway? Well, certainly if you have a pallor more than cupping. Pallor is always a worrying sign, and you should think of doing neuroimaging. Perhaps people with headaches. Asymmetry is questionable, but if it's very severe in one eye compared to the other eye, that's also perhaps you should consider a neuroimaging. Of course, people who have rapid progression of visual field loss or visual loss is another worrying sign. Atypical visual field defects, particularly those which are very close to the central fixation, or people where you have midline defects obeying the vertical meridian. And anything that's atypical that looks a bit strange for glaucoma, you should consider neuroimaging. So in terms of once you are diagnosed normotension glaucoma, the management again will depend on various factors, but IOP reduction is still the mainstay of management because studies have shown that a reduction of IOP, actually by 30%, can prevent progression of visual field loss. And I'll be covering with you two studies, the CNG-TS study, as well as the LOGIT study. Now, I'll also consider other IOP-independent factors, and there's often a query about looking at the blood pressure, particularly nocturnal dips. I'll cover this. Of course, sleep apnea, whether you should use calcium channel blockers. For very severe cases, should you try other medications such as ginkgo or vitamin B3? There's not much evidence for these treatments. As I mentioned earlier, nocturnal dips in blood pressure is important. Ensure that BP is not over-treated because a very low ocular perfusion pressure may also be associated with normotension glaucoma. And particularly people who are on timolol may be also something you need to look at. And you may have to ask the patients to occlude the tear duct to reduce systemic absorption of timolol. Of course, looking at systemic beta blockers as well. So in terms of medications to lower IOP, usually I use prostaglandin analogs, and in some instances also carbonic anhydrase inhibitors or combinations would also be possible. Now we will cover the possibility of using brimonidine, and this is in terms of neuroprotection from the LOGITS trial. Try to avoid beta blockers, maybe because of the risk of nocturnal systemic hypertension, as well as possible vasoconstrictive properties. So let's cover two big trials. One was the Collaborative Normal Tension Study Group, or CNTGS trial, and this was done in the 1990s. And the objective of this trial was to determine if the IOP plays a part in the pathogenic process of normal tension glaucoma. This is a randomized controlled trial from 230 patients from 24 centers. And they defined normal tension glaucoma with optic disc loss, glaucoma's loss, and visual field defects, with IOP of never recorded more than 24, with a median of 20 in 10 baseline readings. So perhaps this is not truly a really low pressure, but this is how the trial designed. And what they did was they were randomized to be either untreated or IOP lowered by at least 30%, and they could use medication, lasers, surgery, or a combination of them. And they looked at visual field and optic disc assessment. And what happened was, in the final result, they found that the progression rate was greater by almost 3 times in those who were untreated compared to those who were treated by at least 30% IOP reduction. You can see here the Kaplan-Meier, the better outcomes in those who had at least 30% of IOP reduction compared to untreated group. So this shows at least a good evidence for the first time that the IOP is part of the pathogenic process of normal tension glaucoma, and therapies effective in lowering IOP at least by 30% would be beneficial in patients who are at risk of progression. The next big trial was the low pressure glaucoma treatment study, or LOGITS, and this is also a randomized controlled trial. And here patients are randomized to either brimonidine 0.2% twice daily or timolol 0.5% twice daily. And again, they were recruited patients with normal tension glaucoma, and they were at least 30 years old. And here they were diagnosed, defined as less than 21 on diurnal curve before medication and randomization. So in this trial, they recruited 190 participants. There were more females, and many cases were unilateral, with about a third bilateral. And they found that the mean untreated pressure was about 15.5 to 16. So it was much lower than the CNGTS trial. And over the follow-up of about almost 3 years, they found that in terms of IOP reduction, they were similar in both groups, but you could see here from the graph that the IOP reduction actually wasn't very great. It was only about 1 millimeters of mercury from about 16 to 15. So it wasn't like the CNGTS trial where you needed to lower the IOP by at least 30%. Here, they were just looking at 2 different medications. And it was showed that both drops had modest IOP lowering of about 1 millimeter of mercury, but they were similar. Of note, about almost a third of the brimonidine-treated patients discontinued the study because of drug allergies within 3 years. And this is quite a high rate of discontinuation, and about 11% in timolol group also discontinued. So this is quite a high dropout rate. But for those who completed the trial, and this was, of course, after excluding almost 40% of people, they found that those treated with brimonidine had a much lower rate of progression compared to timolol. So the rate was 9% for the brimonidine group versus 39% for the timolol group. And I suppose, and this is, of course, very significant, but it was a bit surprising that timolol group progressed so much by almost 39%. So this is also a bit surprising. But the conclusion for this trial was that low-pressure glaucoma patients treated with brimonidine who do not develop ocular allergies are less likely to have visual field progression than those treated with timolol 0.5%. So this is perhaps the first trial showing you protection in terms of lower risk of progression without significant IOP lowering. And you can see here, the IOP lowering was just about 1 millimeter of mercury, and similar with timolol, but much lower rates of progression in brimonidine patients. Now, what about laser? I think in normal tension glaucoma, really laser or ALT or SLT it's very modest effect in terms of IOP lowering because the baseline pressure is often low already. But of course, you could try it, especially for those who are non-compliant. And there's also the option of surgery, particularly for patients who have significant visual field progression in spite of IOP lowering. And there's some studies from Japan where they found when you reduce the pressures from 16 to 11, and after trabeculectomy with mitomycin C, there was significantly slower visual field progression in patients with progressive NTG. But of course, it did not completely stop over 6 years. So in some patients, there is some effect of lowering the pressure even more by surgery than if you just use medications. So this is, of course, the often the last resort, but you certainly have patients. I have had patients in my practice as well, where nothing works and patients still progress in spite of 30% or even more IOP lowering, and then you need to consider surgery. So in summary today, I've covered with you the current thinking about normal tension glaucoma. And remember that many patients with glaucoma have IOP in the normal range. So don't think that just because the IOP is well within normal, they cannot have glaucoma. In fact, most patients with open-angle glaucoma probably have IOP in the normal range, especially if you look hard enough in the population. Secondly, I think it's a spectrum of a disease, it's a continuum, and normal tension glaucoma is one spectrum, with the higher pressure glaucoma the other end of the spectrum. And of course, it's not one disease, but it's actually subtypes of disease. And some patients have IOP independent factors in them. So particularly, you may have patients with vasospasm, you may have patients with migraine, others would have high blood pressure issues, and others with sleep apnea or even low CSF pressure. So this is a spectrum, and not everybody will have the same risk factors. Certainly, you should look out for these factors because some of these factors could be treatable. In terms of management of normal tension glaucoma, studies have shown that IOP reduction is beneficial and at least aim for a 30% reduction in IOP, although it's already quite low. You should try to reduce by 30%. And of course, the LOGITS trial showed the possibility of having some additional effect from brimonidine compared to timolol in terms of slowing the visual field progression. And of course, look for other IOP independent factors to whether they could be managed as well. Thank you for your attention. Can the audience hear me or hear my talk just now?
Would you like to take up questions now or later on?
Oh, now we can hear Shangri-La.
Yes, we heard.
Okay, I can hear you now.
Can you?
Can you hear? Yeah, would you like to
Yes.
take up questions now or at the later session?
Madam, could you hear my talk just now?
Yes, we could hear.
Okay, thank you.
We could hear you, but do you hear us?
Yes.
Can you hear us?
Yes, I can hear you.
Yes. Yeah, do you like to take up the questions now?
Yes, I can.
Yeah, would you like to take up the questions now from the audience?
Yes.
Yes. Could you please come up with the questions if you have from the audience? Thank you, Professor Tim On. So I'm very much grateful to you. Taking our invitation and accepting the invitation and spending your valuable speaker, Dr. Mudita Kulathunga.
Defect in the visual field. When you look at bodies, structure or function of both. So primarily should be based our diagnosis of glaucoma on structure or function or both. So all this research led me to think that we have based this on both structure and function. Even our clinical knowledge, we feel that we have to put both structure and function into consideration when we are diagnosing a glaucoma patient. Like say one domain, the structure, the changes in that will be depicted in the other domain, that is function. Then the diagnosis becomes easy, but it is not as straightforward as that in certain cases, as you know. So therefore, the thing is that even though there have been a lot of studies, the retinal ganglion cell loss corresponding to the changes in the structure of the optic nerve is still poorly understood topic. I could see something like this, where you see inferior 5-layer neural ring, inferior notch, and then OCT having a inferior Then you have a retinal nerve fiber defect and a superior arcuate defect. Then the diagnosis is obvious. So this is structure plus function tallies, then you can diagnose glaucoma easily. So, but it's not so in cases of early glaucoma. Like say glaucoma suspect, sometimes you don't know. Sometimes you have a structural change but no visual field defect. Sometimes you have extensive visual field defects but no structural changes. This is sometimes normal. So in these cases only the problem comes. Can you put the OCT and the input from the OCT and visual fields together to formulate some structure functional index? So people have tried that. Evaluation of the combined index of optic nerve structure and function for early glaucoma diagnosis. Like say, they have concluded the certain studies say yes, we can have a common understanding of arithmetic model to predict the the cases of suspected glaucoma going into glaucoma patients. But some studies have not proven that. There are several studies which says both yes and no. So I have tried to put some studies later on to show you that it is not as straightforward as we think. But what we know is in early glaucoma, the structural changes occur without any visual field defects initially. When the Hopkins ratio changes from 0.3 to 0.6. But when it goes from 0.6 to 1, the structure remains static, the functional changes progress. So in early glaucoma, structure is important. In late glaucoma, the function is important. So one uses the measurement of one domain to support the interpretation of other domain. Now all this is because the depth of retinal ganglion cell related axonal loss that's what we are checking. Now all these studies done on evaluation of structure function relationship of glaucoma, they're trying to formulate some form of index. But this, the unit should be a linear unit. It can't be the decibel to structure. Decibel, the function relationship of decibel to structure cannot be is not linear. So the unit should be linear. The decibel is not a linear unit. It is a logarithmic unit. So, now very often you see, as I said, the certain individuals that the clinician get confused whether it is glaucoma or not. Now something like this, if you see this picture, you cannot superior defect. But in this picture, there is a very drusen-like thing and an inferior defect. So this kind of cases you get confused. So what are the modalities available for structural assessment? You can do the OCT, which we commonly use, and scanning laser ophthalmoscope and scanning laser photometry. Now, in early glaucoma, there is a functional latency period which the structural changes occur without functional change. That's what I said, 0.3 to 0.6 is the functional latency period. Now, in advanced glaucoma, it's the other way around. If you see this, then you know that the structure will remain static, but there is continuous visual field loss, rapid visual field loss. So, is that a good test? Yes, the standard automatic perimetry is a good test in checking the function. Now, if you see the response to a stimulus, the volume size 3, even a small loss of retinal ganglion cell is detectable by this way. So this is like, say, all depends on the reference luminance and the luminance of the target. But this decimal value is not interchangeable between perimeters. Therefore, this cannot be used in for all perimeters. It is not equal. Decibel again is a non-linear measurement. When converted to linear units, it has direct relationship to the retinal ganglion density of the retina being tested. So if you see the central retina has a higher density, it's more sensitive. And for you to get any changes in the central retina, lot of ganglion cells should die. But whereas in the peripheral retina, when the few ganglion cells die, also you get changes. So, but these values can vary with ganglion cell dysfunction, media opacity, and stray light within time. Then later they found pattern ERG and multifocal pattern VEP and multifocal ERG detects glaucoma earlier than changes in the retinal nerve fiber end thickness. If you see this picture, the pattern ERG in normal person amplitude and in the private open angle glaucoma, this the amplitude is reduced. So the pattern ERG is the summed activity of the retinal ganglion cells, and also in different individuals it can be actually it's a summed activity. Therefore, the individual variation is not there in this if you do pattern ERG. Whereas if you do the retinal nerve fiber analysis, the individual changes are there. Even VEP, multifocal VEP is the sum of retinal ganglion cell input to the visual cortex. So in early glaucoma, multifocal VEP amplitude is reduced before a demonstrable reduction in retinal nerve fiber thickness is detected. Now, there is a linear relationship between depth of visual field defect to the percentage of retinal ganglion cells damaged. When the measurements are made, this has to be made in linear units. Now, if you take the non-neural component, now in structural changes, if you see, for example, the decibel, in decibels, if you check the sensitivity is 0, but retinal nerve fiber layer thickness is not 0, it is of 4460. That is because there is some non-neural elements in this measurement, that is like glial tissue and the blood vessels. So, very advanced glaucoma also you get some retinal nerve fiber layer thickness. Therefore, to prevent this error, we have started measuring the Brooks membrane depth opening, Brooks membrane opening, the distance between the ends of the Brooks membrane. So that will reduce the structural individual variations in the size of the disc that we get in OCT pictures. If you measure this, it doesn't vary in individual, like it will be mainly the parameters of the Brooks membrane opening. So now to overcome this, one is the other thing that we can do is to measure the retinal ganglion density of the macular region, which is less variable, which has less variability from individual to individual. So the ganglion cell analysis is a better thing when you consider that. We have, as a clinician, we can check this. So the macular ganglion cell analysis is less variable subjectively. So the other things, when you measure the structural measurements, the quality of the image, lens opacity, cylindrical error of the refractive errors, and poor acuity of the patient, all that matters for this measurement. Then low and then again operator and instrument variability also comes to this picture. Therefore, it's not a very straightforward thing. So when you consider structure versus function, you have to think about both together rather than individually deciding on the structure and function separately. So when you are deciding on a glaucoma suspect, whether this person is going to get glaucoma. The probability of getting glaucoma, we actually still can't predict based on the structure function index. So, we have to put that together into our mind and make it. We still don't have a mathematical model to base our diagnosis. So, it is required to get more data based on integration of structure and functional tests, and to help to make the mathematical model using basically some mathematical model to predict the progression. Then to identify glaucoma suspects as going to let's say get putting them into the glaucoma group can be done only if we can identify this structure function loss and if we can quantify it. Right now we don't have that for our clinical setting. Right. Thank you very much. So I just want to say, think about the glaucoma, early glaucoma, structural changes, late glaucoma, functional changes are more important. And also glaucoma suspects, you have to follow. We can't say that which one is going to get glaucoma in future. Thank you.
Thank you very much, madam. We'll take up the question at the end of the session. The vaccine talk is triggered new ideas among us to have very good glaucoma care. Thank you so much. I'll introduce our next speaker. I'm happy to introduce Dr. Martha Fonseca, who is joining us today in this physical meeting. She's a consultant ophthalmologist with a special interest on glaucoma, and she's working in Girls Eye Hospital, Girls Hospital, and she will be talking on glaucoma current concept. Please accept.
Good evening, everyone, and thank you, Chairperson, for the invitation. I will be speaking on glaucoma current concepts. When treating glaucoma, we need to address 4 questions. Why are we treating the patient? What are we treating in our patient? When are we going to start treatment? And if so, how are we going to treat our patients? We all know why we treat glaucoma. Glaucoma is a chronic progressive optic neuropathy which eventually leads to blindness if untreated. And the goal of glaucoma treatment is to maintain the patient's visual function and quality of life at a sustainable cost. If you compare glaucomatous glaucoma with normal visual decay, you can see that even in a clinical treated population, the glaucomatous group will have a 10 times greater chance of losing visual function than the normal population. And if they are untreated, sorry about that. Right? So the common rate of progression in a treated population, mean rate would be about 0.6 decibels per year. Normal visual decay is 0.07 decibels per year. So even at a clinical treated group, will lose 6 decibels in 10 years. An untreated group will lose as much as 1.1 decibels per year, giving rise to a loss of 11 decibels in 10 years. You can see the gravity of the situation if you don't treat the patient adequately. So early and effective treatment means that you can save additional some years. So just treating the mean treatment is not enough. We need to aggressively treat our patients if we want to give them additional service. So by saving, by reducing the intraocular pressure by another 1 to 2 millimeters, reduction would give the patient additional sight years. By reducing the 0.6 decibel per year loss to the 0.4 decibel loss, giving the patient additional sight years. So it is very, very important that we start treatment early and also treat them aggressively. So Mudita described about the structural changes and functional changes, and I will go on to clinical aspect. Now, progression is usually assessed by visual field function, but unfortunately, to see a change in your visual field, you need to lose as much as 50% of the retinal ganglion cells. So, in early glaucoma, we must rely on the structural test together with our clinical examination. Because the retinal nerve fiber thinning occurs very early in glaucoma. And then there is this flow effect where your OCT becomes of not much use when the patient's disease becomes advanced. When the visual functions become the important tool. So it's a very slow progression, but of course you can watch the MD and the visual field index in early glaucoma patients. So changes in both would indicate that the patient is progressing. So it's not entirely useless. So if you compare what the structural change and the functional change, that I mentioned before, that there's a rapid decline in structure. Retinal nerve fiber thinning is very rapid during early glaucoma. This is more or less static. But at this point, visual field functions start to decline very rapidly. So unfortunately, we usually detect glaucoma here. Most people detect glaucoma here. But what we want is to detect glaucoma in the pre-perimetric stage. So by detecting the glaucoma here, you can save the patient additional sight years. This is not where we should start treatment. So try to catch your patient in this pre-perimetric stage. So once we decide to treat it, what should we treat it with? Should we reduce the intraocular pressure? Should we go for neuroprotection? Or should we improve the ocular perfusion? The ideal case scenario, it should be all three. But we still have only intraocular pressure as a definitive treatment factor to retard progression. All the major studies have shown that intraocular pressure lowering will reduce risk of glaucoma progression. And that 1 millimeter reduction of intraocular pressure will lower the risk of progression by as much as 10%. Please note this. It's extremely important. Every single millimeter that you reduce in your patient intraocular pressure is extremely important to your patient in terms of sight years. So go for that aggressive treatment, especially where your younger patients are concerned. Higher the pre-treatment IOP, higher the chance of progression. And reducing intraocular pressure fluctuation will reduce the chance of progression. So these are all established facts. So even small changes of pressure, as I mentioned, make considerable difference. Now see, if you take a newly diagnosed patient here, median rate of progression in a clinical population, where you treat normally, not aggressively, but normally, would be here, the middle one. But if you reduce their intraocular pressure by a further 1 to 2 millimeters, you can reduce the rate of progression by another 20%. And you push it there, giving the patient better visual function and greater sight years. Whereas if you're lethargic and you don't bother that much, and the pressure are 1 to 2 millimeter higher than what it should be, then you can see the patient will lose rapidly and lose sight here and go blind. Day before, they should really go blind. So when do we treat our patients? In the presence of increased likelihood of developing visual field damage that will interfere with quality of life during the patient's lifetime. As a rule, higher the pre-treatment intraocular pressure, higher the chance of glaucoma progression, and vice versa. Lower the pressure, lower the chance of progression. Hence, in high tension glaucoma patients, all patients require intraocular pressure low, except elderly patients with early glaucoma, say patient in the 80s with early glaucoma presenting with early 20s pressure. You can keep them under observation without giving the additional burden of buying expensive medication when they have a decrease in income during that period of their life. So you can keep them under observation, watch for progression, and then treat. Normal tension glaucoma, only those patients who show progression require further lowering of intraocular pressure. In the early stages of the disease, please note early stages of the disease, as the chance of progression is only 40 to 50%. However, advanced and end-stage glaucoma, whether it's high tension or normal tension, should all be treated aggressively and lower the pressure fatality. So, if it's advanced glaucoma, you need to get it at 12 or below the target pressure. In end stage, it should be 10 or below. Invariably, obviously, you need to go for surgery. We all know that glaucoma progression would vary from patient to patient. And when we encounter a patient, a newly diagnosed patient with glaucoma, initially we would not know the rate of progression. So the rate of progression, as they go along, the first 2 years you can do 6 visual fields and structural tests to determine the rate of progression. So first 2 years will be in the dark regarding the rate of progression. So you have to have an estimated guess and predetermine the target diagnosis at the time of initiation of treatment and be ready to adjust depending on the rate of progression. So the first 2 years is the crucial period at which time you determine the patient's target intraocular pressure, which will prevent or retard the patient's progression. Now, when we want to treat, how do we treat? So we need to make a decision on whether we are going in for medication or laser or surgery. So how we depend on stage of glaucoma, severity of the disease, pre-treatment intraocular pressure, age of the patient, rate of progression determined over the first 2 years, and others like patient preference, cost of treatment, socioeconomic state of the patient, that is physical and mental state of the patient, is the patient able to put the drop, is there help to put the drop, and lack of surgical expertise. That's a very important factor in determining how you are going to treat your patient. So medical treatment remains the first line in primary open-angle glaucoma, both adult and juvenile, except in end-stage glaucoma, where surgery has to come in, and advanced glaucoma in the young should not be treated medically. So they need to go in for surgery to get the very low intraocular pressure. So why is medical treatment the first line? It's effective for the majority of patients, as we have very potent medications for the prostaglandins today, and they're generally acceptable because it's a once-day dosing and is widely available and no surgical expertise is required. However, it requires good compliance on the part of the patient, both adherence and persistence, to achieve a good 24-hour control. And don't forget the cost. This is lifelong treatment. So cost has to be taken into account. How do we choose the most appropriate medication? It should have the greatest chance of reaching the desired target intraocular pressure, should have the best safety profile and tolerability profile, and should be affordable It should be minimally inconvenient for the patient, like once daily dosing, and maximum likelihood of the patient adhering to the regimen. We usually start with monotherapy. If intraocular pressure reduction is inadequate with monotherapy, you need to switch to a different class. You can switch between the prostaglandins. But please don't use two prostaglandins at the same time. Use more than one agent only if it has demonstrated efficacy, but it's not sufficient to reach target IOP on its own. Do not combine two drugs with the same pharmacological action, and do not use two fixed combinations containing overlapping categories. In instances where a very large IOP reduction is needed, it may be necessary to start with more than one active agent. In the 40s, you are not going to start with monotherapy. You need at least two variations. You're all familiar with this treatment algorithm. I'll quickly go through this. The first choice of monotherapy should be a prostaglandin, unless the patient cannot afford, or the patient is a child where they would prefer harmonic antagonist inhibitor. And if with your monotherapy you achieve the target IOP with no the tolerability is good, then you just continue to keep them under observation, maintain the target pressure. If the target pressure is not met with monotherapy, you need to add a second drug. But if there is not a when you give a drug, there must be at least a 20% reduction of intraocular pressure to say it is somewhat effective. If there's not even a 20% reduction, then you need to switch the drug to a different drug. Whereas if there's a 20% reduction, but it has not helped you to achieve target pressure, then you can add your second drug. And if that gives you the target pressure required, then you can follow the patient up. Otherwise, you need to switch monotherapy, and if everything fails, you need to move from another mode of treatment, like surgery or less obviously surgery in most cases. Now, this is what I really wanted to tell you, that some interesting new treatments coming your way. So, of those, Rho kinase inhibitors or ROCK inhibitors have been there and talked about a lot over the past couple of years. They help low intraocular pressure in a unique way by improving the trabecular meshwork, that is, by reducing the resistance at the level of the trabecular meshwork. Yeah, primary open angle problem is there. So it increases aqueous humor outflow through the trabecular meshwork. And it also decreases aqueous humor production and decreases episcleral venous pressure. That is, of course, but by not the Rho kinase inhibitors themselves. In most cases, they add a non-regulatory pathway inhibitor to the drug, to the ROCK inhibitor. So therefore, the drugs where both are combined, all three methods of action will be there to reduce the intraocular pressure. Very interesting concept. So how does it work? The metabolic pathway of Rho kinase controls many aspects of cell morphology. When inhibited, the change in cell shape and active cytoskeleton structures occur. And when Rho kinase pathway is blocked, cell bodies become grounded and there's disruption of actin production. Resulting great outflow of aqueous humor with reduced resistance through the trabecular meshwork, leading to a decrease in intraocular pressure. Many Rho kinase inhibitor drugs chemically include an norepinephrine transport inhibitor, which causes vasoconstriction with reduction of blood flow to the ciliary processes, giving rise to reduced aqueous production and reduced episcleral pressure. Japan has already given the approval, which was way back in 2014, to start on ribosudil 0.4 twice a day, and it is being effective. USA has given FDA approval in 2018, I think latter part of 2017, for the use of ribosudil once a day. The studies are ongoing. Some have been completed. ROCKET 1 and 2 have been completed. Now ROCKET 4 study is going on, where they are comparing timolol with the ROCK inhibitors, and they have found equal efficacy. So you might wonder, why are we so excited if it's only equal efficacy? But remember, timolol has a lot of side effects. Whereas low kinase inhibitors, the only side effect is conjunctival hyperemia. New studies are going on, Mercury and Mercury 1 and 2, that is comparing Glaucoma and ROCK inhibitors separately against the combination. And they have found an additive effect by the use of both together in one bottle. That is, the pressures are supposed to be going down 1 to 3 millimeters more if you use both in one bottle. And that is because when you use both the trabecular meshwork pathway as well as the nucleoscleral pathway is active. So I think this will be the crux of the future. I'm most excited about vitamin B3 oral supplement, also called niacin and nicotinamide. How does vitamin B3 work? Mitochondrial dysfunction is an important, if not essential, component of human glaucoma. Vitamin B3 derivatives are protective against reactive oxygen species. One of its derivatives is nicotinamide adenine dinucleotide, which is a key molecule in the metabolic cycle. As we age, the level of NAD plus in the eye decreases, more so in glaucoma patients, making the cells more vulnerable to disease insights. William and colleagues showed in 2017 that reduction in NAD plus and antioxidant glutathione in the eye render ganglion cells more vulnerable to protein pressure inside in glaucoma patients, thus increasing NAD plus levels by consuming vitamin B, which is protective of ganglion cells. Going to be a wonder drug. Studies are already going on. Some studies have been completed using high-dose vitamin B3. So is vitamin B3 the neuroprotective agent we were all impatiently waiting for? Time will tell us. So right now, 3 grams a day, the high dose is being used. And the 12-month study has, the 4-month study has come out that is pretty effective duration. So they are waiting for longer duration studies to make it an established way of treating glaucoma together with your pressure lowering drugs as well. Then don't worry, your pressure lowering drugs won't go on the market. These are additional medication which would give a neuroprotective effect to the patient. Okay, thank you. Otherwise, there are 5 things that I'm going to
Would you like to, Dr. Fonseca would like to take up some questions because she wants to give please come up with some questions.
Unfortunately, we don't have B3 commercially available here. So what I do is I ask my patients to get it down from the floor. And I say any brand is okay, but I'm a little reluctant right now to give the high dose of 3 grams. So I'm giving 1 gram, hoping some benefit will be accrued by the patient. I'm waiting for further results to see whether 3 grams is the appropriate dose, because I read some articles where above 3 grams, sometimes if your body weight is low, it could occur at 3 grams also. That intraocular pressure can rise. And just one report in the USA journal says that macular toxicity also has been reported. So I would say if you're thinking of starting, start on those doses. And patients who cannot afford, this of course I've been doing for a long time, giving vitamin B complex, hoping that the vitamin, because vitamin B has an effect on nerves. And I must say, for the past 10, 15 years, I've been giving it to patients with absolute end-stage glaucoma, and I've done the surgery everything. And as an ex-commercial, because I know vitamin B complex is not going to harm the patient. So what is the level of vitamin? And I must say, it's sort of unbelievable that they're hanging on to the little bit of vision they have. Probably could be partly due to the effect of the people. Harmless medication, I must say I give to all my patients. So those who can get it down from a dose, they get the B3 itself, and they take 1 gram at night, otherwise they take every factor of the complex that you have some amount of life. If the harmless medication is not going to cause any harm to your patient, if it's in excess, it will pass in your disease.
As a patient, 16 years old.
16.
Yes, 16 years old, and when you look at the risk, suspicious that the glaucoma, and when you do the investigations, intrusives are normal, and retinal five layer fluctuates between 76 micrometers and 72, 1 or 2 higher or lower, 1.5 years.
Is it going down or is it fluctuating?
From time to time.
So that means that's not a proper estimate. If you can go up now,
Yeah.
it has to be either going down or up. So in those cases, the most important thing. This is why I'm trying to stress. Intraocular pressure is the most important thing.
And pressure is 40.
Yeah. So for a 16-year-old, that's a normal. Normal pressure is 12 to 14. Right? So 16, I would treat the patient. Otherwise, I would keep them under observation. So it depends on the degree of confidence. So if is a low, you
And
retina.
published strength is 0.7.
Yeah, so that factor is quite keen for the 16-year-old. So if you're no factor. So higher the pressure, more the chance of going for treatment. Lower the pressure, keep them under observation. No, depends on the CCD. Center corneal thickness plays a major role. Yeah, so that can be considered as normal. You can keep them under observation. And
So in 4 months we are going to
yeah. If you're keeping them under observation, the first 2 years I would watch them every 4 months. And at the end of 2 years, if they're stable, I make it 6 months for another 2 years. And then once if they're stable, it will be a year. But if they start out with high pressures, I personally would think that it is better to on treatment because they disappear suddenly. And I have had bad experiences where I have kept them under observation, and every time you say you're fine, you're fine, you're fine. So from 4 to 6 months to a year, and they disappear. And they come back 5, 6 years later, gone slow. They're not back. Because they also become
the pressure is 16, we are going to start.
16, yes, I would consider looking. Of course, I have to see the patient, see the nature of the disease, and then decide. You can't just go by, no, each patient has to be individually assessed.
We are going to start with.
Approximately. 16 years, I would first go in actually, if it's less than 18 years, I would go for carbonic anhydrase inhibitors. Otherwise, I would go for over 18, I would go for the first one. Always remember, higher the pressure, on treatment. Lower the pressure, on keeping them under observation in the early stages of glaucoma. But if you're keeping them under observation, you must be absolutely sure that is the type of patient who will come to follow up. If you feel the patient is not a reliable patient, better to treat. Any other questions? Thank you.
Thank you, Master. It's a very informative and there are new concepts which is an eye-opener for all of us to have a better present and future glaucoma care. Thank you so much for very informative. Just I would like to introduce our next speaker, the Dr. Dibani Avisinha. She is a consultant ophthalmologist, Golden Key Eye and ED Hospital, Colombo, Sri Lanka. And she is the immediate past president of the College of Ophthalmologists of Sri Lanka and member of Women of Ophthalmology Standing Committee NPAO. And I will invite you to talk on laser for annual closure glaucoma.
Good evening. I thank Dr. Lakis for inviting me to this talk.
and I'm really glad to be a part of this meeting after a long time. The topic I'm going to discuss today is lasers for angle closure. It is a regular procedure that we do in our day-to-day practice. So at the outset, I thought I'll just give a brief introduction to what is angle closure. Angle closure is actually a group of diseases where you get either reversible, that is appositional, or adhesional, that is synovial closure of the anterior chamber angle. This is the revised angle closure classification, and that includes primary angle closure suspects where you get narrow occlusal angles with normal intraocular pressure. Then primary angle closure attacks where you get sudden acute rise of intraocular pressure. And primary angle closure glaucoma where you get associated glaucomatous optic neuropathy. So one needs to know the underlying mechanisms of angle closure before deciding on treatment. So they include mechanisms that pull the iris forward from behind, such as pupillary glaucoma, plateau iris, bulky anteriorly displaced lens, or malignant ciliary glaucoma. So when we suspect angle closure, we need to perform gonioscopy to make a diagnosis. Then we can do anterior segment imaging to confirm the diagnosis or assist our diagnosis. So when we confirm the diagnosis of angle closure, what are we going to do with these patients? How to decide on treatment? The treatment or the management of angle closure depends on the underlying mechanism of angle closure. And if there is significant cataract, if there's no cataract, or if the patient is unwilling to go for cataract surgery, and if the underlying mechanism is relative pupillary block, then we can consider laser treatment. And if there's significant cataract, the best thing is to go for a phacoemulsification and remove the cataract. Then if there's associated glaucomatous optic neuropathy, we can either do a combined phacotrap or combined phaco-corneal synovial axis. So in this talk, I'll be discussing only this arm, that is laser treatment. So laser peripheral iodectomy was first described as a replacement of surgical iodectomy in late 1970s. It can be performed with argon alone, Nd:YAG alone, sequential argon Nd:YAG, or frequency double 532 Nd:YAG diode Pascal laser. So it is indicated in acute angle closure attacks, fellow eyes of acute primary angle closure. The studies actually have demonstrated that there is a 50% risk of angle closure attack in the fellow eye without a peripheral iodectomy. And it is also indicated in all stages of chronic angle closure glaucoma and in angle closure suspects where you get narrow occludable angle. So who does argon, pure argon PL? Anybody? No. Who does pure Nd:YAG peripheral iodectomy? Okay. And who does sequential LPI? So others, they don't do anything. Fine, so argon, although it's effective in dark eyes, it has a higher failure rate and subsequent closure rate. And is also associated with a 10% risk of endothelial cell loss and retinal burn. So Nd:YAG iodectomy replaced pure argon due to high rate of single treatment success
and lower risk of subsequent closure. But in highly pigmented eyes like ours, high levels of air glaze energy was required, and up to about 40% of cases were complicated with iris bleeding. So therefore, we now opt for sequential organ in the laser eye drop. So sequential LPIs reduces energy requirements for peripheral hydrotomy and often kills out iris trauma without generating pigment clouds, and it is associated with less iris bleeding. So the treatment technique involves pre-treatment with pilocarpine and brimonidine. Unfortunately, right now in Sri Lanka, pilocarpine is not available. And one needs to decide the site of the iridotomy prior to embarking on treatment. Ideally, we need to treat in an area of the iris crypt if present. And no other pre-treatment is necessary in Caucasian iris. So what is the LPI size? Ideal size would be about 150 to 300 micrometers. The Asian eyes require larger iridotomies because small iridotomies can be associated with closure and may not effectively relieve the pupillary block. There can be a resistance to the flow through the iridotomy if it is small. So, as practicing ophthalmologists, we have been trained to perform LPIs immediately adjacent to the 12 o'clock position here. But the current evidence suggests that this is not the optimal site for LPI. Actually, partially covered LPIs with the lid margin can result in linear dysphotopsias and ghosting of the images. It is thought to be due to the prismatic effect of the tear meniscus at the edge of the upper lid. So, placement of the LPI at the 3 or 9 o'clock position serves better with regards to linear dysphotopsia. So this will be a better option than this. So, Abraham or Weiss lens can be used with coupling fluid to perform sequential organ PI. And these are the settings for organ. We use smaller spot size, that is 50 micrometers, shorter duration, and a higher power, followed by 3 to 4 shots of Nd:YAG to 2.5 to 3.5 millijoules. These are my settings. We use Abraham lens, and we have the size frequency double 532 nanometer in the YAG laser has actually replaced our argon, so we use that as the argon, and that's the latest. And then my setting, I use about 900 milliwatts power, 50 milliseconds, and 50 micrometer as font size for argon, and followed by about 3 to 4 shots of 4.5 millijoules in the YAG laser. So initially, we mark the area or the site with the argon and burn that iris with the argon, and then we perforate with the YAG. The perforation of the iris is indicated when there's a gush of fluid into the anterior chamber, gush of actually pigment into the anterior chamber. You can see this very clearly. You can see pigment gushing through the perforated iris. So sometimes performing LPI can be difficult when the corneas are cloudy, in the presence of peripheral corneal opacities like this, and in thick irises, and in the presence of a dilated pupil following acute angle closure attack. PI also can be complicated with iris bleeding, but if you hold the contact lens and if you exert a slight pressure with the contact lens, usually bleeding can be stopped. And then you can continue with the procedure. Sometimes it can get complicated with pigment clouds generated by the yak. Then what will you do? We can leave the patient for a while, and maybe you can even use steroids and redo the PI at the same place without whacking the iris at different places with ND-YAG, because that will generate more inflammation and more pigment dispersion. So following LPI, we need to manage the IOP spikes with acetazolamide, and we need to discharge the patient on adequate topical steroids for at least 1 to 2 weeks. And we need to review the patient following after about 2 to 4 weeks. And at the review, we need to check the patency and the size of the iridotomy. And it is crucial to repeat the gonioscopy at the review to see whether there's widening of the angle. If the angle is unchanged, we have to consider other mechanisms of angle closure in those patients. So how to check the patency? We can retroilluminate the pupil, peripheral iridotomy, and see whether it's patent. But sometimes transillumination can be deceiving in the presence of a fibrous membrane. The peripheral iridotomy can close immediately after the procedure due to pigment debris, or later it can close due to pigment perforation and covering the opening with a thin fibrous membrane. We can perform, if you are not sure of the patency of the PI, if you have the facilities, we can perform anterior chamber imaging, cross-sectional imaging, and see the precise condition of the PI. But if you do not have the facility and if you are in doubt, best thing is to enlarge the peripheral iridotomy to adequate size, at least 300 micrometers. That would be the idea. So, peripheral iridotomy can result in severe anterior chamber inflammation, so it's mandatory to give steroids following the procedure. So the clinical outcome can vary following the iridotomy. Angle closure may persist despite a good functional patent PI. It could be due to presence of peripheral anterior synapse or due to the presence of other mechanisms of angle closure, such as angle crowding or plateau iris. So it is crucial to perform a gonioscopy after the LPI. So management of LPI, patients should not be discharged from the clinic. They should be watched for the development of glaucoma. So after LPI, if the angle is open, if the IOP is controlled, still we have to monitor the patient. And if the IOP is not controlled, then we can resort to other modalities of treatment, like medical management or surgery. Studies have demonstrated more than 90% of the eyes required for the medical treatment and more than 50% of the eyes required surgery within the first 5 years following LPI for chronic primary angle closure glaucoma. So you have to be careful, you can't just do a PI and discharge these patients from the clinic. Laser PI alone may not be effective in certain other conditions where the underlying mechanism is not the pupillary block, such as in the presence of thick iris, plateau iris, or in the presence of a bulky anterior displaced lens. In these conditions, laser hydroplasty comes into play. Hydroplasty is also known as gonioplasty. It was invented as an attempt to modify the peripheral iris in late 1970s. Hydroplasty uses low energy burns to contract the peripheral iris and pull the iris from the angle. to widen the anterior chamber, and it can be performed as an adjunct to the peripheral ichthyotomy. So laser light here in angioplasty, the argon laser light is converted to heat, resulting iris stromal collagen to contract, which is responsible for the anatomical change in the iris. It is indicated for plateau iris syndrome, narrow angles despite of a patent peripheral ichthyotomy in patients with non-ophthalmos, microphthalmos, or in the presence of angle closure, particularly with peripheral anterior synovial. So how can we perform arthroplasty? We use Abraham lens or single mirror lens with coupling media. These are the other settings for the arthroplasty. We use moderately high power, large spot size, and longer duration. Ideally, 6 to 8 spots should be placed in each quadrant, or a total of 30 to 50 applications over 360 degrees. At least we have to allow 1 or 2 spot diameter distance between the two shots. Contraction of the iris and deepening of the peripheral anterior chamber should be the endpoint. So where to treat? Treat the peripheral iris without encroaching the trabecular meshwork, and you can increase the energy level depending on the tissue contraction. You have to notice a contraction of the iris during the procedure. And this is, I don't know if you can see, here of course you can see, this is how the hydroplastic burns are applied to the periphery of the iris. These show improper application of the hydroplastic burns to the periphery of the iris with no effect for the angle. So lack of response or contraction should be due to inadequate energy, improper application like in those pictures that I showed you to the central iris or mid-periphery of the iris, or presence of multiple peripheral synechiae or over-treatment and resulting in coagulative necrosis of the blood vessels. So post-laser is similar to the management following LPI. We again need to repeat the gonioscopy following arthroplasty to evaluate the anterior chamber angle. It can get complicated with mild iritis, corneal endothelial burns, IOP spikes, and particularly that can result in peripheral anterior synechiae. So you need to give adequate steroids to prevent peripheral anterior synechiae because iris becomes sticky and gluey, and that can result in peripheral anterior synechiae if you do not give adequate steroids. So I thought I'll conclude my presentation with a case report. This is a patient who was referred to us following a PEI and an hydroplasty with high uncontrolled IOP. What can you see here? There's a PEI, patent PEI actually, and the hydroplasty burns are little too central. And we perform the ASOCT imaging. The angle is still closed, and this concavity of the iris was due to the hydroplasty burns, which are placed slightly too central with no effect on the angle. So when you look at this patient, what else can you see? There is significant cataract in this patient, and also that patient had significant glaucomatous optic neuropathy. So we perform, what will you do then? No point keeping the cataract in this angle closure patient. This thing is to take the cataract off. So we perform a phacotrabeculectomy in this patient. And you can see how the angle has widened after removing the cataract. Same patient, pre and post-op. You can still see the iris concavity, but you can see the nicely widened angle after the cataract removal. So I think your angle parameters have widened drastically. So in a summary, the management of angle closure depends on the underlying etiology. If there's cerebral block, you need to do laser peripheral ichthyotomy. And in the presence of plateau iris or thick iris, we need to do laser hydroplasty. If there's presence of bulky anterior displaced lens, the thing is to extract the lens to prevent them going into angle closure glaucoma. So everyone should know how to perform a LPI and hydroplasty because it's a site-saving procedure. Because when we get patient with angle closure attack, acute angle closure attack, we can't be referring the patient to somewhere else for a PI. With that, I conclude my presentation, and these are some fun memories what we had in 2019 when we hosted the APAO Glaucoma Symposium in Sri Lanka. Hope the pandemic will resolve and hope to have another meeting like this in the near future. Thank you.
As there are no online questions, you can ask quick questions from the audience. Are there any questions? As no questions, it's a very great presentation, Niruna. Thank you so much. And you have highlighted the great points in this lecture. It's very informative. Thank you so much. The next speaker is Dr. Ronnie George, our international speaker, who will join virtually with us today to talk on structure versus function. Sorry. When in front of advanced glaucoma, Dr. Ronnie George, the senior consultant, ophthalmologist, Department of Glaucoma, Central Health, Chennai, India. Please join us, Dr. George.
Thank you for the kind invitation. Are my slides visible? Anyway, I'll assume that they are, and I'll go ahead. So why do we need to actually think in terms of target intraocular pressure? That's because even after we detect glaucoma, there are people under treatment, 27% of whom may go blind during their life, in one eye at least, and 9% have a chance of going blind in both eyes. And this risk is higher in certain races. In fact, when you look at studies across the world, you find similar rates of between 11 and 20%. The World Glaucoma Association consensus statement states that the target intraocular pressure is the IOP range at which the clinician judges that progressive disease is unlikely to affect the patient's quality of life. So the aim is not only to prevent blindness, but to also maximize the patient's vision related quality of life. And this always has to be balanced against the burdens and risks of therapy versus the risk of progression. So this is a schematic from the recent European Glaucoma Society guideline, and it basically tells you all the factors that you take into account when you look at a target intraocular pressure. So you look at the likelihood of symptomatic vision loss, and you balance that versus the life expectancy, the rate of progression, and the initial glaucoma damage. You look at additional risk factors which could increase the risk of symptomatic loss or decrease it, and you look at the adverse consequences of intervention. And as always, keep the patient's preference in mind, and the status of the other eye is very important because in a one-eyed patient, all of us are that much more careful about it. So when you look at a stepwise assessment of a target intraocular pressure, the first step is to estimate the amount of glaucoma damage. This is based both upon structural and functional assessment, but functional assessment or visual fields are more important in detecting how much damage we consider this patient to have. For example, a visual field like this and an optic disc like this, you would definitely look at the mean deviation because that would give you an idea of how much whether the patient has mild, moderate, or severe disease. This patient probably has moderate disease based purely on the mean deviation, but when you look at paracentral points being depressed over there, you might consider that this is somebody who's at a slightly greater risk of significant visual loss because of the paracentral point involvement. The second step is to estimate the damaging intraocular pressure. And this is the importance of getting good baseline untreated intraocular pressures. So even if you have a patient who's come to you from somewhere else, you should try and find out what the baseline untreated intraocular pressures on Goldman operation tonometry were there. If the IOPs at presentation are not very high or in the normal range, take multiple intraocular pressure measurements because fluctuation is always a consideration in these patients. The third step is to estimate the patient's life expectancy. And I'm going to spend a little bit of time on that because the longer the patient's life expectancy, the lower the target IOP will be. And we're fairly good at estimating visual field damage because we have the visual field machine. We are fairly good at estimating IOP because we actually measure it. But we are really not good at estimating life expectancy because we just have a figure in our mind which is can be problematic. And I share our experience with you. We looked at about 400 eyes of open-angle glaucoma, basically patients who we thought were stable. And we looked at their visual field at baseline and the visual field, the final visual field just before they came to us, the number of years between these two fields to get a rate of progression. We then looked at life tables from insurance charts to figure out what their potential life expectancy was. And then we extrapolated the rate of progression to that life expectancy to see what the final mean deviation would be at the end of the estimated lifespan. And that from that, we calculated the proportion of people who are at risk of visual disability in their lifetime. And what we found was that you would get perimetric visual impairment of minus 20 decibels in about 28% of these patients. And 22% of people would actually lose vision if they continue to progress at this age. And don't forget that the mean rate of progression was actually fairly small, just 0.5 decibels per year. We had a few people who were at minus 4.5, and there could have been some contamination with cataract here. But 50% of these 400 patients were at risk of visual disability or blindness in one eye. And this is something that we need to take into account. And the reason why we underestimate life expectancy is because, especially in countries like ours, which are developing rapidly, life expectancy changes dramatically. For example, this is the life expectancy in Sri Lanka. Just about 50, maybe 70 years back, your life expectancy was around 52. Today, it's 77, and it's projected to keep increasing. So when you look at this life expectancy and you look at a life table for Sri Lanka, if you are 50 to 54 years old today, you are expected to live another 27 years. If you are 85 years old today, you are expected to live another 7 years. So just because somebody is old, don't think that they're going to live, not live that long. The older you are, the older you will live. And this number keeps increasing. Just in the last 2 years, you can see the difference at every time point has increased by about 1 to 2 years. So as this is a figure that we need to keep reassessing when we see our patients and as our patients get older. The fourth step is to consider the other risk factors for progression, and these include severe damage to the other eye, a family history of blindness from glaucoma, factors such as pseudoexfoliation. All should be taken into account when you assess risk. And this is again a graphic from the European Glaucoma Society guidelines, and I think is one of the most comprehensive ways of looking at it. So we have now established how much glaucoma there is from the visual field. We have established what the life expectancy we estimated to be. We have established what the untreated intraocular pressure is. We have looked for additional risk factors, and based on these 4 parameters, we will decide a target intraocular pressure. The last parameter, rate of progression, is something that we will need to do going forward from here. So let's look at this. Now, this is somebody who came to us with a baseline intraocular pressure of 40 versus. I'm just giving you 2 situations. One where you had a baseline IOP of 40, and the second where you had a baseline IOP of 18. I showed you this slide before too. And the current intraocular pressure is 16 millimeters of mercury. Obviously, we would be very unhappy with this sort of an IOP reduction in somebody whose baseline IOP was 18. But somebody who was 40 will be reasonably happy with this, even though because you've got a very dramatic intraocular pressure decrease there. So is there a way of calculating the number? And there are multiple formulae. Now, this is one formula which takes into account the maximum IOP, and it calculates a Z, which is an optic nerve damage feature, which takes into account optic disc and visual field changes. And based on that, you come up with a formula like this, which is the maximum IOP minus 30% of maximum IOP minus Z, and you would come up with a target intraocular formula like this. Is just one of the many formulae available. But I'd just like to tell you at this point that the consensus is that the current target IOP is estimated and cannot be determined with certainty in a particular patient, and that there is no validated algorithm for the determination of a target. So while a target IOP formula is useful, it's not a magic bullet that is going to help you to make a decision in a patient. So a lot of the decisions that we make on target intraocular pressure come from these studies. And I'll just share with you a few examples. For example, now if you have an intraocular pressure of 30 millimeters of mercury at baseline, and you manage to reduce IOP at 20% if the patient is ocular hypertensive, you would probably be okay with a 24 millimeters or 23 millimeters of IOP in an ocular hypertensive patient who's otherwise low risk for progression. On the other hand, somebody with established disease, you're looking at maybe 40% intraocular pressure reduction, such as was suggested by the CGS study, and that works out to about 18 millimeters of mercury. If you now look at somebody who had lower intraocular pressures of, let's say, 24, 23 millimeters of mercury at presentation, and you use the same 20% reduction, your IOP reduction for an ocular hypertensive comes down to about 18, and for established disease comes down to about 14. And this range of about 12 to 18 millimeters of mercury is where most of the target intraocular pressures would reside. It's difficult to medically get the IOPs to less than 12, and we look at less than 12 only in very, very specific situations. And if you look at the American Academy guidelines for target intraocular pressure, for people with mild damage, you're basically looking at high-risk ocular hypertensives or preperimetric disease, a reduction of 20 to 30% from baseline. For patients with advanced damage, you're looking at 40% or more from baseline. Normal pressure glaucoma, Tim also alluded to this, the reduction of 34% from the baseline was fairly effective. And the ocular hypertension reduction of 20% from baseline is fairly effective. This is basically just a thumb rule for us to follow and should not be taken as an active guideline, because how well this intraocular pressure reduction does in helping us treat the patient depends on this. Is the patient progressing, and how fast is the patient progressing? So when you look at retinal ganglion cell loss, this grayed out area below is the threshold for significant visual impairment. So you can have somebody who progresses like this, or you can have somebody who progresses very rapidly like this. And this is the reason why you need to actually estimate rate of progression. Rate of progression is the most important factor when it comes to preserving vision in these people. Because without estimating rate of progression, you might actually miss rapidly progressing disease. And based on the rate of progression, you would need to both identify rapid progressors and titrate your target intraocular pressures. Keep in mind, this is another example for the same thing, and keep in mind that age is important because you have B and C, both of which are showing you the same slope, the same rate of progression. But because C is much younger at the time of diagnosis, if he continues to progress at this rate, he will definitely have significant years of visual impairment. While B, because he's older at diagnosis, with this rate of progression, may be able to live his life without having severe functional impairment. So when you look at individualized target intraocular pressures, once you have decided what the target IOP is, if they are stable, you follow up, and at each visit you look for progression. If they are stable, continue to monitor whether the target intraocular pressure is reached. If it's reached, you can reevaluate and decide whether you need to reduce medication. If the target IOP is not reached, you consider accepting a higher target intraocular pressure or add treatment, reevaluate if they're still stable. If they're progressing, obviously you aim for a lower target intraocular pressure and go through the same cycle all over again. I'll share with you a couple of cases. One is this 56-year-old lady with early POG who was started on treatment elsewhere. Intraocular pressure when she presented to us was 14 millimeters of mercury in the right eye and 30 millimeters of mercury in the left eye. We reviewed her case reports, and her baseline intraocular pressures were 36 and 32 millimeters of mercury. She was started on travoprost. On day 4, IOPs were 32 and 26. She was started on timolol. On day 8, brimonidine was added because the IOPs were 27 and 24. And on day 15, dorzolamide was added because the IOPs were 24 and 22. So this is unfortunately something that happens, and this is something that we should not do because you need to wait for drops to have the effect before adding additional medications. And unless you do this, you are increasing the medication burden and increasing the treatment-related side effects for the patient. And we could actually reduce 2 medications in this lady and keep her well controlled at around 16 millimeters of mercury on just the prostaglandin and timolol. The second gentleman was an 84-year-old man who had been following up for a while. Hypertension, diabetic, post-coronary bypass. He's on treatment for CA prostate. He's a known case of primary angle closure glaucoma, post-LP and cataract surgery. Intraocular pressures was 17 and 16 millimeters of mercury. He was on a travoprost and timolol combination and had mild ocular surface disease, and he was a little uncomfortable because of that. When we reviewed his fields over practically the last 10-12 years, he's been pretty stable, even though he has moderate damage in the right eye, the left eye is being nearly normal. We switched to preservative-free travoprost. Intraocular pressure 6 weeks later was 19. And given his age and his medical profile, we basically realized that the possibility of significant visual impairment in his lifetime was minimal, and we kept him on the lower medication. So target intraocular pressure is a dynamic value which keeps changing. So if the patient is stable for a while, you can consider modifying medications. If there is progression despite your target intraocular pressure, re-estimate and recalculate your target IOP even lower. When we look at advanced glaucoma, and I'll talk briefly about it, it's basically what are our concerns. Our basic concern is that there is not much buffer preventing this patient from reaching visual impairment. Therefore, we need to do good risk assessment. We need to get multiple intraocular pressures because a patient may be fluctuating outside office hours or at different times of the day. And if we miss that, we will calculate our target IOP according to that. Or on follow-up, if we miss that, we will actually miss IOP spikes. They require close follow-up. I would consider 3-monthly follow-up in these patients to assess the rate of progression. When there is advanced damage, I would try to get, if possible, 4 fields a year, if not at least 3 in the first year. I would use 10-2 for serial follow-up if there is threat to central fixation. Aim for at least 40% IOP reduction. Start with the prostaglandin and have a low threshold for treatment escalation. Give time for the drug to act. If your target IOPs are not reached or there is progression, you will have a very low threshold for surgery. One of the concerns for surgery is always that, we talk about the wipeout phenomenon. I would like to share with you this study we did 2 years back, which looked at the early visual loss following glaucoma filtration surgery in eyes with split fixation. So we included patients who had at least 1 point on the paracentral, one paracentral point where the thresholds were 0 decibels, either on a 10-2 or on a macular program. And this is the size 3. And we follow them for at least 2 months after glaucoma surgery. And this is the distribution of the preoperative and postoperative. Most patients actually were below 20 decibels. So this is fairly severe glaucoma. And in this group, we basically looked at 65 eyes, and we found no change in 90% of patients. That's the number of points where there was a split fixation was the same. In 10% of patients, the number of split quadrants increased in 7. Visual acuity remained the same as that of the preoperative level in 2 of these eyes and improved in the rest. So the risk of macular wipeout is small and should be balanced against the risk of progressive glaucomatous damage, even in advanced disease. So don't be hesitant to operate in these patients if they're progressing in spite of reasonably good IOP control. And as always, give adequate time for the drug to act before checking IOP or before changing treatment. So to summarize, target IOP should be individualized as per the patient and should be flexible as it is ever changing based on the progression of the disease or the increase or decrease in risk factors for the patient. And keep in mind that the methods used to maintain target IOP should be sustainable over the long term with minimal adverse events, because that's the only way the patient is going to continue taking the medications. Thank you once again for the kind invitation.
There are no online Are there any questions from the audience? As there are no questions, I'd like to thank Dr. George for sharing us with the very informative thoughts and the facts in the target IOP and how to achieve it and the importance of achieving target IOP in advanced glaucoma. It's very informative and very challenging for all of us for managing the advanced glaucoma. Thank you so much again.
Thank you.
I would like to invite the last speaker of our sessions, Dr. Dushyant Vadyapura, one of our eminent speakers, who will talk on detective progression of glaucoma. Dr. Vadyapura is a consultant ophthalmologist at Sri Jayawardena Hospital, Kotte, Sri Lanka. He is the current representative of the Asia Pacific Academy of Ophthalmology. He was past president of SAC Academy of Ophthalmology 2014 and past president of the College of Ophthalmologists of Sri Lanka 2006. And he is a past chairperson of the Group College of Sri Lanka and member of Board of Study in Ophthalmology, Postgraduate Institute of Sri Lanka. Please accept my invitation.
Thank you for inviting me, and then we're going to talk about detecting glaucoma progression. How do I move this? Okay, so by definition, glaucoma is a progressive disease, and there are structural as well as functional defects. The structural defects are noted here. So you can look at the disc, the RNFL, the ganglion cell analysis. You could even do OCT angio and look at the blood vessels of the disc and the macula. The optic disc could be checked with the color photograph. Stereo disc photograph could be even better. And maybe document the CD ratio. The RNFL, you could use just photographs like this red ring, and you could use the OCT otherwise. Ganglion cells can be looked at with the OCT. Functional changes, we always use the white on white SAP. SWAP was used some time ago but fallen out of favor now. Electrophysiology, PERG, and photopic negative response, I think Murita talked about PERG to some extent, are the things that we check to detect glaucoma. Now, to monitor glaucoma progression, what you need to do is to look at these structural and functional changes and document them, and then follow them up, longitudinal monitoring, which will detect progression. So look at the changes in these parameters to detect progression. So in early disease, as many people mentioned earlier, maybe you can look at ganglion cell death. Later you could look at RNFL, and then eventually, very late stage, maybe visual field changes may be more important. But as Mudita said, these are not very clear cut. In early disease, sometimes they could present with visual field changes. In late stages, still ganglion cells may be useful, and if you have actually, it doesn't really mean that you don't do the other tests, because there may be asymmetrical disease. One eye may be really late stage, and the other eye may still have about a 0.7, 0.8 up. So you really need to do all these tests in most patients. Okay. So why do we need to detect progression? Okay. Many glaucoma suspects, you know that early diagnosis is difficult. So if you can monitor and detect a change, then we know that it should be glaucoma, as by definition, glaucoma is a progressive disease. And then you can start treatment. Normal tension glaucoma, virtually 50% of them are not progressive. If it is not progressive, you don't really need to treat them. Those who are on treatment, you can, if you detect progression, then you can lower the IOP further. The target IOP, if it was not achieved, you can make sure that it is achieved and lower the target in spite of, if you have already achieved the target and there is progression, then you need to lower that target. And of course, increase surveillance. Maybe if you are doing every year, you could now cut down to every 4 months or every 6 months if you detect progression. So in the disc, we can look at the disc cup disc ratio. If you can document that and see whether there is a worsening, that we know that there is worsening. We could look at neuroretinal ring changes, thinning, which was not there, and the disc appearance, the hemorrhage, just the appearance of a disc hemorrhage tells us that it is a progressive disease. You can see here this hemorrhage, and in the CNKT trial, this hemorrhage was one of the major risk factors for glaucoma progression in the normal tension glaucoma group. So this hemorrhage also tells us that if it was a normal tension glaucoma, if for a glaucoma suspect, now we know that it most probably is a glaucoma and you can start treatment. You can alter treatment if, just like what we said earlier, you have achieved your target, you can lower the target and then change the level of surveillance. If you can serially show in the nerve fiber layer defect enlarging in a color, black and white red-free photograph, then we know that this is worsening. But of course, OCT would perhaps be the better bet, because you can use that to objectively measure these and quantify them. What we can assess are the RNFL and the ganglion cells. These nomograms aren't that great, so what we really use are the RNFL and the ganglion cells. The OCT RNFL can be detected, even small changes in the RNFL can be detected. Even while it is in the green zone. So here you can see that if it is started here, if it drops a little bit even, then if you serially monitor them, you'll be able to detect progression in glaucoma and detect either diagnose glaucoma or treat it more aggressively. And OCT in early to moderate stages, as I mentioned, and we all heard about the flow effect. So they never go below approximately 50 microns. So it would be useful once the RNFL hits the flow. So this patient, this is M in 2016, was having pretty much normal disc and RNFL changes reports. And you can see in 2019 has developed RNFL defect here. So just by comparing these two, you know that this person has developed glaucoma. In another patient here, you can see that in 2019 compared to 2017, a new RNFL defect has occurred, and we know that this most probably is glaucoma. Here there was a suspicious one, but now it's all red, so we know that this most probably is glaucoma. So this is detecting progression through comparison, and you can see that here you can see that this area has got denser, and if you look at these plot covers, yellow has become red. So there is progression. So this is one way of assessing progression. Of course, you can look at the ganglion cell complex. In the Zeiss machine, we look at the ganglion cell layer and the inner plexiform layer, and the other machine, it's all combined together. But we have in Sri Lanka is a Zeiss Cirrus machine, which looks at the BC IPL layer, not the nerve fiber layer. And the OptoView machine looks at all BCIPL plus RNFL. In glaucoma diagnosis and progression, it is useful to monitor over time. And this patient, you can see in 2016, the same patient, this is M, had hardly any defect in 2016, but there was some query one there, though RNFL didn't actually have a defect, and in 2019, an obvious defect here. So we know that there is progression in this patient. This is consistent with what we saw earlier in the same patient in the RNFL. And this lady again there is in 2015 versus 2019, there is progression in the ganglion cell defect. So that guided progression analysis, of course, is more useful because it can quantify, objectively measure, and statistically analyze the changes. There are two ways of measuring: the trend-based analysis and the event-based analysis. Trend-based means that the latest OCT compared with the previous OCT, and serial progression can be seen, and the rate of progression can be calculated. You need 5 tests to determine the slope. Event-based analysis looks at the latest OCT with the 2 first baseline OCT. You cannot measure rate of progression, but flags a change of about 8 microns with the 4 micron intertest variability, which is about twice the SD. So what do we recommend? I think this was discussed about 6 within the first 2 years in ocular hypertensive and glaucoma suspects, at least baseline and annually. In this patient, you can see the trend analysis in the RNFL thickness and the event analysis and the trend analysis. And here what you see in the printout is the RNFL thickness change. The average is here, the superior average is there, and the inferior average is here. CD ratio is also plotted here. And on this graph here, you can see whether it is likely possible or likely progression in the maps, the profiles, the superior, and the CD ratio. They are flagged as either yellow, impossible, and likely more red. And the event analysis also looks at it similarly and flags it possible in an orange here, and if it lasts beyond that third one, so you need at least 3 to flag the orange and at least 4 to flag it as a red. If it remains in the second one, then it flags as a red, so likely progress. So this is another patient who has progressive damage in the average, the superior, the inferior, RNFL, and that is flagged in the event analysis as well. And this is the ganglion cell analysis. Here also you can use the event and the trend analysis. You can have that showing us whether there is worsening. When we come into visual fields quickly. Well, how does visual fields get worse in glaucoma? Existing defects may enlarge virtually 50%. Existing defects can get deeper. That's the most common way of worsening. And other areas getting involved, again, about 50%. How do we assess progression? We can just use clinical judgment, look at 2 visual field charts, and see whether one is worse than the other. It's easy to perform, but there is very poor agreement among evaluators when you use that. So just looking at the overview printout. So here is just the overview printout. You can see the total deviation and the pattern deviation plots. It's very difficult to detect a deepening of a visual field. You can easily see an enlargement or a new visual field defect coming up. It's easy to see, but it's quite difficult to see a worsening of a defect. And it is not really using the statistical analysis that these machines, the visual field analyzers, are capable of. So here is one patient, just looking at 2 pictures, you can see obviously that there is worsening compared to this versus 2015 versus 2019. And when you see this, it's pretty obvious that there is progress. But unfortunately, most of us use this method and still the most prevalent method. But of course, you can look at the global indices, the mean deviation, the pattern deviation, glaucoma hemifield test, and the VFI. But it's better to use statistical analysis, the trend and event-based analysis. We can look at mean deviation, the pattern deviation. You can look at the probability plots, the total deviation and the pattern deviation, and see whether glaucoma hemifield test becomes normal, changes to become abnormal, and look at the visual field index. Now, visual field index, I just mentioned a little, represents the retinal ganglion cell loss as a percentage of normal. Here, the central, compared to the MD, the difference is that central points are given more weightage. From mean deviation, it's 0 to 30 decibels loss. Here, it's starting at 100 down to 0 at the end. So visual field progression is seen if you can show increased MD deviation, increased PSD. One thing about PSD, pattern standard deviation, is that with glaucoma getting worse, it goes up to about 10, 12, and then with the glaucoma becoming even worse, it tends to come down because the pattern, it becomes more global and the pattern is lost depth, and that leads to a pattern standard deviation becoming less. And then, of course, the decreased BA5. We can quantify the visual field progression, event-based and trend-based. It gives both the trend and event-based the summary. It's a single-page report. You can see that the two up here are the two baseline readings, and here it is the VFI plot and the VFI bar, and this is the current visual field, and event analysis is mentioned here. Trend analysis evaluates the test parameters just like the OCT. Test parameters sequentially detects the rate of progression based on linear regression analysis. You can use either MD or VFI, but most of us now use the VFI. At least 5 exams must be there to detect progression. VFI 100 to 0, tracked over time, indicates the progression, and it also predicts the VFI during the next 5 years, the VFI bar, what could happen to this patient over the next 5 years. One interesting thing that happens is that the VFI also uses the pattern deviation until about minus 19 to 20 decibels. And after that, it jumps to using the total deviation. So when the mean deviation hits around 20, you might see a sudden jump in the VFI. It doesn't mean that there is a sudden jump in the loss of visual field, but it is just a statistical way that it is used. The mean deviation goes beyond from 18 to 20. Here, the VFI will show a bigger loss. So, like in this patient of mine, a 65-year-old lady who was well controlled, 0.7, 0.8 cup. Now, we realized that in 20 January versus 21 January, the VFI dropped from about 45 to 38. The mean deviation just jumped from 19 to 20, 21. So it's a small drop. The VFI has dropped a lot. So that is because the VFI now uses the total deviation instead of the pattern deviation. So event analysis is also possible. Here is an event analysis graph that shows black half white square triangles, half black triangles, and full white black triangles. So what do they mean? The white triangle is progression at 95% significance level. The half black is the same point repeated in 2 consecutive exams, and a full black one would be repeated in 3 consecutive exams. If 3 or more points are flagged with half black triangles in 2 consecutive exams, it gives you a possible progression. If 3 or more are flagged with full black triangles, it denotes a likely progression. So here is just one example. Here, the 2 baselines are not really good, but the trend analysis seems to be good. But there are a lot of black triangles here, but it has not lasted long enough. So there is just one. I think has been seen in 2, and there is a possible progression here. There's another patient who seems to have very good trend analysis, hardly any change. Another one with good trend analysis, and these all crossers. So these crossers mean that it is out of range. To begin with, it is too dense and you cannot really see any worsening. And this is a patient who seems to have a pretty normal trend analysis in the visual field, but shows an RNFL defect here. So RNFL defect on OCT perhaps is seen earlier than visual field defect. Here is another patient who shows a visual field trend analysis, which is quite normal, stable in the right eye and deteriorating in the left eye. And that is seen again in the OCT, but in the right eye here in the OCT, you can see a slight red area there. So there are limitations both in event-based analysis and trend-based. Event-based, I think the main thing is it does not consider the interim results. And trend-based ones, you need at least 5 exams to detect a change. In advanced glaucoma, as I think was mentioned, RNFL may not be useful in really advanced glaucoma. Ganglion cell analysis reaches the flow later, so may still be useful when RNFL hits the flow. Visual fields 24-2 is still useful when the OCT hits the flow, but you can use the 10-2 when the visual fields defects are extensive. So how do you assess 10-2 visual fields? You'll have to look at compare the old versus new, but you can use the forum to generate a graph and use monitor the MD. VFI is not available with 10-2. You can just use the MD, mean deviation, and use forum to get a graph. Thank you.
As there are no online questions, you can ask 1 or 2 questions. Thank you, Dr. Valipura. It's a very informative and very serious lecture. And very serious lecture. And
One question.
Yes. Yes. Now, Valipura, you said that you can do the analysis, progression analysis, both visual fields and ganglion cell analysis.
Yeah.
How do you select in which patient? You are able to do both in all the patients, or in early glaucoma patients, which one is more sensitive? Are you planning to do both, or sometimes?
No, I mean, I routinely do visual fields and OCTs in all glaucoma patients. Only in early patients, I do everything. In very late glaucoma patients, if both eyes actually are 0.9 and only a very small area is visual fields are remaining, then I might just do 10-2 or 24-2 visual fields only. But commonly what happens is maybe one eye is 0.9, the other eye is 0.8. 0.81 has still RNFL. So in most of them also I do all exams. It's easier to tell them to do a complete test rather than select.
Yes, but my question is, which one is more sensitive to detecting the progression?
In early glaucoma, everybody feels the consensus is that RNFL and ganglion cells perhaps even earlier, might detect changes compared to visual fields. In very late glaucoma, when RNFL hits the flow, ganglion cells may still be useful. So the OCT has to be done. If that is also virtually has hit the flow, then maybe visual field, and visual field 24-2 is not useful, then you use the 10-. So practically, most patients will need both the OCT and the visual field. Once you do the OCT, you can get the ganglion cells and the RNFL anyway. And so, but the answer perhaps is in early glaucoma, that's what everybody was talking about. But on the other hand, there are newer reports which say still, if the RNFL has not hit the flow, even in late glaucoma, RNFL and ganglion cell defects may show progression, which is still useful in addition to the visual field.
One more question. You said you need at least 5 examination reports to assess the progression in visual fields. How the time gap?
Yeah, so to get the trend analysis, you need 5. But the recommendation is do baseline 4 months, and during the first 2 years, do another 4. So altogether, you have 6. But to get a trend analysis, you need 5 visual field examinations. Without that, you can't get. You can get event analysis in 3, but to get likely or possible, again, you need about 5. So to use the statistical features that the visual field machines are capable of.
Over a period of 2 years? Or
No, it doesn't matter. I mean, that's just a statistical thing. Whatever, if you give the machine 5 exams, it will come out with a statistical report. Obviously, I mean, you have to do it over a certain period of time, but it doesn't mean anything. You can even 10 years, if you have 5, it will generate a report. But it's the recommendation is to do 6 within the first 2 years. But that is in glaucoma patients. But if you have a non-glaucoma glaucoma suspect, I'm sure you are not going to do that. You may be doing it once a year or something like that.
Thank you.
Thank you, Dr. Bharat, for a very stimulating lecture on progression. And thank you. Just we have to conclude our event by I invite Dr. Hiranya Abeseka to do a word of prayer. He is the Joint Secretary for the Ophthalmology of Sri Lanka. Thank you.
Thank you, madam. I know it's not fair to prolong the agenda anymore. So let me thank quickly for the people who contributed for the success of this workshop. First and foremost, I would like to thank our foreign international lecturers, Professor Kim Moore and Dr. Ali John, for their very excellent lectures full of new facts. And not to forget our local experts who share their knowledge, Dr. Mr. Putunga, Dr. Bata Fonseca, Dr. Evan Arifin, and Dr. Shankar Arifin. Yes, Madam and Sir, thank you very much for your presentations. And I want to thank the Glaucoma Interest Group, particularly the very energetic chairperson, Dr. Agda Kalpasela, for organizing this workshop. And as you know, it's impossible to carry out workshops of this magnitude without financial support and technical support. And the sponsorship and the technical support was organized by Elegant Sri Lanka. My sincere thanks goes out to Mr. Hassan, the business manager of Arabian Sri Lanka and his team. Thank you very much. And also big thank goes out to the staff of the college office, Ms. Amanmali and Mr. Mahesh. They have done a lot of groundwork to organize this workshop. Thank you very much. And last but not least, your participation. Physical and online participation in this type of workshops is very, very informative for us to organize many more Indian scientists in the future. Thank you very much and enjoy the experience.